So I want to extend my warmest welcome to Dr. Madhukar Trivedi and Sara Levinson Eidelman. Dr. Trivedi is a professor, chief of the Division of Mood Disorders, and director of the Comprehensive Center for Depression in the Department of Psychiatry at the UT Southwestern Medical Center. His research focuses on pharmacological, psychosocial, and non-pharmacological treatments for depression. He is the winner of several grants that support his essential research. He is a teacher and mentor of countless students who follow in his footsteps, and he has published more than 420 articles and chapters related to the diagnosis and treatment of mood disorders. He is the president-elect of the American Society of Clinical Psychopharmacology and was listed by Thomson Reuters' World's Most Influential Scientific Minds as one of the nation's most highly cited researchers in psychiatry over several years. Our program will begin today with a conversation about your work and why it's especially important now. Then we'll turn it over to Sara, the Senior Project Manager at the Center for Depression Research and Clinical Care at UT Southwestern, so that she can present on a new tool that can help us monitor our own mental health and improve well-being through self-awareness and tailored feedback. So if you have questions, we will open the room in a few moments later on, so please hold on to them. And if you're watching on Zoom, you can also type your questions in the chat, and we'll include everybody in the conversation. So here, let me give you this microphone. It's an honor to have you here. Thank you for being with us today. So this conversation is to mark the beginning of May, the Mental Health Awareness Month. Thank you for spending your Saturday with us. As we begin, I would love to hear you talk about what inspired you to study psychiatry and specifically mood disorders. How did your relationship with the field begin, and how has it evolved?
So, can you hear me? So I thank you for the question. I haven't thought about it in that way, but maybe let me try. I think it is very clear that we as in society anywhere, and I grew up in a different society and thought that the ignorance about this is very high, and was very clearly enamored by this country and thought that the ignorance will be lower here. And you find out that there is just immense ignorance about this. It is a very common condition, and yet we don't really understand most of it. And the biggest challenge is, as a result, we either ignore it or we are scared of it, and so therefore nothing really changes. And so 1 in 4 people in the United States will have some experience with mental health in some time in their life. This is more common than a lot of illnesses. More people die from suicide than die from breast cancer every year. Double the people die from suicide than homicide, and yet the political world is so much enamored and focused on what to do with criminals, and nobody really pays attention. So that's the first part. And the second part is, I think it's a brain disorder. And brain still remains one of the most exciting organs in the body that we don't understand enough. And so, anybody here a nephrologist? Maybe somebody's on the Zoom, so please pardon if you feel offended, but kidney, we know everything about it, so I didn't feel like studying it, whereas the brain is a wonderful, amazing organ. It develops, it gets challenged during development, it gets changed, has toxicity from environment, from nutrition, from drugs, from alcohol, from physical sexual abuse, and yet has the capacity to actually regenerate, has neuroplasticity changes, and we can recover from it. Some of you may even know of examples where somebody has a stroke and they can't walk, they can't talk, and 2 years later they are actually in a gym doing things, and that is the capacity of the brain, and we don't capitalize on it. So that's one thing. The other thing is, most major medical illnesses we worry about actually happen late in life. Alzheimer's, everybody knows and worries about. Diabetes, high blood pressure. This is a pediatric illness. It starts early for most people, and yet, and unfortunately, you live a long life, and yet, that is what you live with for the rest of your life. Imagine a 16-year-old. Anybody can raise your hand if you know somebody or have had somebody in your life who's had depression. And you know, those of you who didn't raise your hand is only because nobody in your life told you that they had this. This is so common. And yet we end up ignoring. Anybody take a 16-year-old to their pediatrician, any mothers, fathers do it occasionally, I'm a father, so I know, but mothers take the 16-year-old to a pediatrician. The pediatrician will very easily measure height. They'll ask the person, mother and the child about weight, about eating habits, about their sports. They will even measure their head circumference, their blood pressure. But they won't ask about depression, anxiety, or alcohol use. The chances that that 16-year-old is going to have high blood pressure are so close to zero, I can't differentiate. But they will have a high rate of depression, anxiety. Nobody asks. So I think it's both a challenge and an exciting opportunity. I don't want you to leave you with feeling depressed about this. So I'm going to tell you this. If you get the right diagnosis and the right treatment, 80% of people will get better. Tell me about any other medical illness where that's possible. So we have both an opportunity and a challenge, and I go after simple solutions. So that's the...
Thank you. So this was actually my next question, but you began to touch on it a little bit. What do you think are the biggest obstacles or misconceptions that we have about diagnosing and treating mood disorders that prevent folks from getting the care they need?
So I think challenges are twofold. One is there's a long history of psychiatry doing hocus pocus, so I have to confess. I mean, there were people doing kinds of treatments that lasted forever and didn't change anything. There is a famous Oshraf case in the early 80s where a nephrologist was in a long-term psychiatric hospital for 8 months, and was a nephrologist for that matter, and did not get better. At some point he decided, I'm going to go home and kill myself, leaves, because he can't stand another session with the therapist who is talking about all the other things that it's not going in, and finds a doctor, says, I'm going to give one more shot, finds a doctor who starts him on imipramine, which is an antidepressant that was available at that time, and 3 months later is back at work. Jerry Clairman, who's the father of psychopharmacology in the United States, testifies on his behalf, and there is a famous Oshraf case that started our journey to change the way but still there is a lot of, so that is the first thing. And the second is, I think people get scared. I am a psychiatrist, so my wife is a family physician, and then we go to a big gathering, and people come to us and say, what do you do? And she says, I'm a family physician, and they talk for 5 minutes about, I see a 9-day-old and a 90-year-old, and there is a lot of exchange. They turn to me and they say, what do you do? I say, I'm a psychiatrist. They walk away. And I can promise you, I can't read your mind. So I think that there is both a kind of a twin, I don't know what it is and I'm scared, is the main issue. And I think if we can do something, but what you are doing, all of you, is more important than what I can do. And that is the community has to get engaged. The community has to want it. The reason anybody turning 45 today suddenly gets a colonoscopy is because Katie Couric did a virtual colonoscopy and everybody in the society says, we are going to do this. I think we need something like that with mental health. I think the COVID pandemic has taught us something, that if we as a society take a challenge on, we can solve it. And my hope is we can do that for mental health.
Beautiful, thank you. What do you think is the most important finding, or one of the most important findings that you've uncovered in your research? And because you're so heavily cited everywhere, how have you seen that finding penetrate your field and change the way that folks approach it?
So it's bad to ask an academic, right? Because I can sing eloquently about all that, but I will leave that alone. As in, I can tell you everything about brain circuits we've found, et cetera, et cetera. What I will tell you, which is where my life's work has made an impact, is not get scared and measure what's going on. So make it allow for parents to allow for their kids to talk to them, so that if they are not feeling well, they're feeling depressed, they're having thoughts of death, they talk to their parents and take them to a pediatrician, or you can. So that is the biggest lesson I have learned, is that use a guided measurement-based approach like we do for high blood pressure, like we do for diabetes. If people are given permission to reveal what they're feeling and thinking, and we measure these things, we can diagnose people early and we can treat, and once we start right treatment, most people get better. So that is the biggest finding of my work, even though the basic research that we've done that has been funded is very essential for me to get here, but I think that is what I like most. And I think Sara should talk more about it, because that is the place where we have gone into the community and made the biggest difference of what we can do. And that should become routine. I think it should be my wish. Thankfully, I'm not a politician, but my wish is that the mayor and the county commissioners say that nobody in our county is ever going to go undiagnosed and unmeasured for depression, anxiety, and alcohol use. If we can do that, we could change it.
Oh, absolutely. And then my last question, and then I'll turn it over to Sara, is in this moment, at the end of a really emotionally taxing year, what do you think is our most important takeaway in terms of taking care of ourselves and our loved ones?
I think find a way to get everybody vaccinated so a grandmother can hug her grandchild. I think the social contact is so essential. We have all learned this. I think we have to move back to that, and as soon as we can. That's the first lesson. And the other, like I said, is if we put our mind to something, we can solve it. Those are the two things I would say.
Beautiful. Thank you. Sara, over to you.
Shabbat shalom, everybody.
Is this mic working yet? Yes.
Can you hear me? I can project.
Here, there we go.
Hello. Hello. It's a privilege and an honor to be here in person in the sanctuary. I was thinking back to the last time we were here, and it was for Tiny Treasures, celebrating all the babies in 2019. So thank you for the opportunity to be back.
It's great to have you here, Sara.
I'm excited. So one of the things that I'd really love to talk to you about today is this new self-monitoring tool that has been a vision of Dr. Trivedi's for some time now. And we call it Avexia, which is the Greek word for wellness. And the idea is that we are empowering individuals to take control of their mental health and their self-monitoring. You go to the doctor's office. If you're lucky, maybe they administer a patient health questionnaire 9 or a GAD-7 to measure your symptom domains for depression and anxiety, but it doesn't happen always. And if you do complete it, they may or may not address it. So what we've been focused on now is giving individuals those same self-monitoring tools to take in the convenience, whether it's on a phone, on a computer, at their disposal, whenever they're ready, to complete measures on their own. They receive personalized feedback based on the responses to each symptom that they endorse. Over time, as people complete measures, the feedback changes. So as your responses change over time, perhaps you get continued recommendations for each specific symptom domain, or you'll receive affirmations. Hey, guess what? You've made it so many weeks, your symptoms are doing well. Keep up the good work. We also have the ability to have reports that you can view online. We've got a nice little speedometer gauge. It's color-coded based on symptom severity, so mild, moderate, moderately severe, and severe. We track trends over time. These reports can be downloaded. They can be printed. If you choose to bring them with you to your doctor's office, great. If not, you have them for yourself. But the idea is that you are in the driver's seat. You're no longer waiting for that clinician to ask you. And this way, you can see over time how you're doing. And this is really focused on overall wellness and mood functioning. This tool is available for people 12 years and older. There is a parental consent for minors, which makes sense. We require, two-factor authentication, so we want to make sure that you are the person, signing up. You can opt in or out to receive gentle nudges over text or email every 2 weeks, which is the way that these validated self-report measures are intended to be administered. I'm trying to think what other fun features we have with our tool. But it's a work in progress, so we're also soliciting feedback. We want this to be about the user and the individual. So if there's something on the website that you're like, this doesn't feel right, we want to know about it. We're looking to engage in a partnership with individuals to help them, on their wellness journey.
But I think the way to think about it is, my grandfather was 60 when he got a heart attack. That's the first time he found out that he had high blood pressure. We don't want us to get it to a point where somebody is thinking about suicide when you first find out maybe there's depression. So this is an attempt at that and empowering. So now when I was 25 and I was looking at a cheesecake, I love sweets, and I do occasionally ask, do I really need it, because my grandfather had hypertension and had a stroke, had a heart attack. That kind of knowledge is what this is trying to develop. But I think Sara generally is not this quiet and mild, so let me push her and talk to people about how this fits into the full continuum. As the idea behind this, she has done this for our primary care network, and trying to get primary care also to really start thinking about depression, anxiety as something they do, like they do for hypertension and diabetes. And so do pediatricians. You don't go to a pediatrician's office or a family physician's office where they have a board that says, I am so good at treating every medical illness except depression. But that is what ends up happening. And so what we are trying to do is get them to not have that board there and just do that. I'll do very good care for anything you have. And that's what she has actually helped us do for the last 7 years.
7 years.
So maybe talk about that so that people get a sense of this is not just the tool, this is in the setting of making sure that the goal is everybody gets diagnosed, treated, monitored, etc.
So when I first joined Dr. Trivedi, I was tasked with bringing depression screening to primary care providers and primary care offices. We created a program called Vital Sign 6 with the intent of making screening for depression the 6th vital sign. So we actively recruited primary care offices. We taught them, about depression, about measurement-based care for depression, using these validated self-report tools to help the clinicians learn how to diagnose depression and then how to treat depression. And so that every time patients come into the office, they are screened with these validated self-report tools. Over time, our clinics, their remission rates really improved. However, you come against this, I don't want to say time is money, but patients with depression, their visits are more complicated and they take longer. And what we found is that even though our program works, a lot of these clinics just didn't want to use the program anymore, so we decided to turn this on its head. The provider first approach wasn't working, and this is almost think of it as a patient or an individual first approach. We are teaching individuals about mental health, depression, anxiety, overall mood functioning, and wellness, which is why we called it Avexia. We wanted it to be a little different, that made you go, what is this? Why is this important? And because of the way the tool is designed with feedback, you're learning about those symptom domains. You're given recommendations on how to address each one of those. And then if you choose to, you can download that report and take it to your clinician and have an educated conversation with them and say, look, I've been monitoring my mental health over time. I have this graph, I have this trends. These are the symptoms where I'm really struggling. Can you help me? Does that?
Yeah, that's
Absolutely. And
beautiful.
all these ultimately have, which is what you started with, and then I'd like to hear questions. But I think all these are also based in science. So like we've done brain function studies looking at brain circuits, etc., that actually have correlates of this. So like if somebody is exposed to a negative input, somebody criticized. If I go out and on my way out, if I overhear two people say that, you know, this thing was a waste of time, then hopefully it's not. But if I overhear it, I'll have to sort of digest it and maybe do it better next time. If I had somebody who's prone to depression, then that will actually trigger that part of the circuit in my brain that is going to continuously reverberate like it is a broken record which gets stuck, so that for 3 days or 10 days I'll keep on worrying and not be able to function. That is what happens in brain circuits when somebody is not able to process negative emotions. That can be measured. That is what we are trying to actually, and so a lot of these symptoms and functional parts that we are including in the software are related to the findings we have from research, and so that is how we are trying to ensure that this doesn't get ignored because there is lack of knowledge.
Thank you. Does anybody have a question? Yeah, Irving.
Thank you all so much. What you do is...
Can I have your microphone for a second?
Now you hear my Yiddish accent. Thank you, and what y'all do is so very important, and you know, I think it's really interesting, and it's a helpful tool, I'm sure, and it's based on scientific evidence. At the same time, I'm going to ask you a loaded question. You're on faculty of one of the greatest medical schools in the country. What are y'all doing, or not what are y'all doing, what is the medical profession doing in teaching our young students and doctors to be able to work with a tool like this? Because unless you have, yeah, and you talked about the continuum, but unless you have the continuum, the tool itself can only do so much, I'm sure.
Thank you. And how am I doing with my Texan accent?
Extraordinary.
I think that is a wonderful question, and thank you for asking, because I think that our solution is not just one-off, and so we are really interested in and devoted to doing it through the full spectrum. And you are so right that our biggest impact is going to be in training the young generation, because believe it or not, any doctors here? So you know, sir, but that like it or not, medical practice, people who practice medicine, a large chunk of their practice is related to how they got trained. It's not so much new stuff, so that we have to train the new generation. And so Sarah and I, we've been in clinics that we now adopt are most often clinics where residents rotate through there. So we are now, for example, we did one at the Presbyterian. We are starting one clinic in Methodist that is purely being driven by the residency training program, so that all the residents rotate through there, where we'll use the Vital Signs 6 program and have them train up. And it's almost apprenticeship, so that is absolutely the goal. We are also working with the Meadows Mental Health Policy Institute through the state to make reimbursement requirements that are tied to it. Because like it or not, a lot of healthcare is also healthcare business. And so that is, so you're absolutely right. That is the goal, and we are trying. The bad news is there is a lot of stuff to do.
Yeah, when I started, a Baylor downtown had 5 floors that we devoted to psychiatry. And as the economics of medicine went the way it did, we went down to 0 floors, which, was tragic in my eyes. And, as you'll see in Dallas, there's very few for inpatient and outpatient. So
Thank you. Yeah, Shirley.
Thank you again for being here. I'm president of Sheriff Israel, so it's nice to have you. Nice to have you guys back. So I'm a family nurse practitioner, and back 25 years ago when I was in my master's program and my nurse practitioner program, I remember that aha moment when I was doing my psychiatry rotation, that by asking the question, are you suicidal, will not make somebody suicidal. That, it was like, I don't want to plant the seed, that you're not planting that seed. So I guess my question would be, what do we as either healthcare providers or as the general public, what are the questions we should ask people? That is, hi, how are you? I'm fine. How do you get past that to say, what are the 3 or 4 questions to tease out in a non-professional way, clearly, because you're trying to help your family and friends? What are those questions that may make a difference when you're really coming up to somebody that may need help but can't ask for help, and you want to be open and honest with each other?
Thank you again. That is exactly what we are trying to accomplish. And so, but first, the myth part, which is what you just mentioned, but bears repeating. I don't, and especially parents of younger kids who in their teens, remember teens immediately after puberty is the first hit when most people with depression start experiencing some symptoms. So do not ever feel like if you ask the young person or even an older person about depression, anxiety, suicide, that you're going to put that thought in their minds. Not happening, never happens. In fact, I'm the father of 2 boys, now older. I wish that were true, because then I could have forced them to do everything I wanted. Nothing happened. They have their own brains and their own minds. And so please never, ever, even if you ask an 8-year-old, are you feeling, are you having bad thoughts about hurting yourself, thoughts about not being here? That will never put that thought in their mind. That is actually essential to answer your question. If you see any change in behavior, any change in the way they talk or their usual routine behavior, I think if it lasts for more than a few days, it is incumbent on us in a social setting, or as in friends or family, to observe that and point out, I have observed, I've seen that you're not going out as much. I've seen you're more irritable. I see you're short when I talk to you. Is there something going on? If there is something going on and somebody in their family life asks, a 10-year-old, if a mother asks, they feel so much relief. So that is how I would say, asking about any change you observe, to ask in a non-threatening manner and allow for that. And parents have to provide the environment where it's okay for them to come and tell them if they run into things like some serious bullying at school, or they're having trouble dealing with friends or romantic relationships, etc. Finally, I think if you see a change in behavior, somebody who's very gregarious and has 10 friends is now saying, I don't want to go out on a Saturday night. If it happens more than a few times, then you again can ask the young person, say, this isn't like you, is something going on? They may not always tell you, but at least I can tell. It is very clear from data also that people feel relief.
Thank you.
Does that answer your question?
Yeah.
Okay, we'll
Thank
do
you.
one more question because I see what time it is. Thank you all so much for all of your thoughts. Lita, or do you know who had your hand up first over here? Was it Glenn?
So go ahead.
Me?
Well,
I'll come to
Glenn
you.
had his hand up first, but I see so many questions. Okay, let's see.
Sorry,
we'll just see
okay, I'll
how
make it
long.
really quick. So
Yeah.
also, thank you very much for being here. Really appreciate it. So 2-part question. One is, I would think one of the challenges you have is, at least in my experience, maybe because of Big Pharma, the psychiatrist, first thing they do is throw medicine at it. Whether you're young, whether it's Ritalin, whatever, you start getting on this whole cycle of medicine, right, without really understanding the problem. 2 is just kind of an interesting thought. I'm curious with social media and what it's done to young people and their mental well-being and their sense of self.
So first question, and I think that's an important one. I think that it is actually correct that there is overprescribing happening in the world, and I think we got to figure that out. There is no reason for a 16-year-old who has depression to always have to have medications. There are many other treatments available. So I agree with you about that, but just because that is happening doesn't mean we ignore it, right? So what we have to do is empower people to know and ask the right questions, and do not ever, and the doctors will agree with me, I bet you, do not ever question changing the doctor if you can't get the right answer. It doesn't mean, I tell patients before I see them that I will be glad to help you, and if you have any concerns, tell me. But there are some patients who don't really like me, and so tell me, I'll help you find somebody. And you should expect that from the psychiatrist. So I don't think the fear of medication should prevent you. The social media thing is actually plus minus. Yes, it creates sort of a false sense of contact, but it leads to isolation. But I don't think that itself does dramatically. I mean, there was the telephone before there was no telephone, and that was criticized. Then there was TV, then that was criticized. Now, so there are pluses and minuses. And we can talk more, but I want to be respectful for some people's questions. So you were raising.
Yeah, thank you, Lita, and then I think Steve, you also had your hand up, and then we'll close.
As a teacher and someone who's working at a preschool, I have noticed anxiety, fear, depression in very young children. And there's one child that's coming into the preschool program who's already being treated for anxiety, which makes me feel good that they're recognizing it. However, when I was teaching, it was very obvious to me that certain children were suffering very badly, and unfortunately the cause was the parents and the parenting. And it was nothing, it was systemic, ongoing, their whole lives. I mean, because I saw them over a couple of years. So my question is there being anything provided to pediatricians to help diagnose these things and to help the children early on so they don't end up being suicidal teenagers?
So our program is geared towards everybody, including pediatricians, and in fact, we are working with Children's Medical Center, and a lot of their clinics are beginning to use our methods. So the short answer is yes, pediatricians should be involved. I think there is also this issue, thankfully kids love their parents, right? So that's good. There's biologically, there's things called mirror neurons in the brain that kids have, all of us have, and the kids have. So some of this anxiety that you're seeing these days at least is basically reflecting what parents are experiencing. And so there again, acknowledging it is probably the most important thing. But yes, pediatricians should be involved and educated, and we are trying and others are doing.
Thank you. Okay, Steve, last question.
Doctor, you touched on something briefly at the end of your first talk where you said, well, we all have to get vaccinated so a grandmother can hug her child again. One of the challenges of this last year of pandemic is depression, feelings of isolation aren't just an actual internal emotional response. It's an actual physical thing that's going to be continuing in the future. And the response can't, of course, merely be pharmaceutical. How are you seeing in your own practice, in the practice of others, how to deal with depression in a situation that's now, in a sense, physically depressing and isolating as well?
So this is an important thing that as we go forward, we in the medical field and in society will need to deal with. And I think the short answer is, and going back to your point, medications are very good and perfect for a lot of people, but not always. And in fact, in a number of people, they don't need medications. And I'll tell you, we do this routinely in our decision making for people who may have bad glucose control and diabetes and treatment for diabetes. Not everybody who has bad glucose control gets insulin. because we there don't get into this debate about is it medication or not. We talk about sequence of treatments where somebody who is just beginning to have that, their doctor says, be careful with your diet, be careful with your nutrition, we'll monitor this every 3 months, let's see for a year. The doctor at the end of the year sits down and says, this is what happened in the last year, you've been doing well with nutrition but still not here, maybe exercise will do this for 3 more, and if not, I will have to start insulin. Same thing should happen with medications and depression. Not everybody needs medications. In fact, there are a lot of, we've at our center done extremely well done large trials. If I'm biased, my trials are always well done. But we've done great large trials with exercise, physical activity, physical exercise with the Cooper Institute as the only treatment for depression where you didn't use medication. So there are other treatments. We shouldn't get into that debate about should it be medication or not. We should be thinking about outcomes.
Thank you. So, Carol Ann, thank you so much for the segue. So at the conclusion of our program, please come up and grab one of these postcards. There's a QR code here that you can scan on your phone to sign up. And in our weekly email that's going to go out Monday, the entire congregation will also receive this link and this information so that we can all sign up for this tool, not just for our own benefit, but also we're in the beta testing phase of Avexia, so we will also help Sara and Dr. Trivedi make sure this program is the best it can be in order to serve all of our populations, all of our communities. So thank you so much. Let's give a round of applause to Dr. Trivedi and Sara. Thank you so much for this wonderful conversation. And you can come on up and say hi and take one of these postcards. And Shabbat Shalom, everybody. Thank you so much.